This final panel did not disappoint. Not at all. Questions or comments for these two? And Cindy is always right off the mark here.
I am forced to go unformed. Cindy Brock, Agency for Healthcare Research and Quality. First, just a quick note on tablets. We won't use brand names, but getting a lot of good press for potential of tablets to be used in informed consent. And I just want to share, totally anecdotal, but we have just completed a demonstration project at the Health Literacy Universal Precautions Toolkit in preparation for edition number 2. And one of the things we did was use tablets because we could get over the literacy barriers and have using talking touch screens, etc. 10 practices around the country, ranging from 2 docs to much larger practices. Half the practices ended up using paper and pencil. That between their internet connections, the patients, the practices discomfort with troubleshooting things, uploading the information, everything. So I just want to point out that I don't think we're quite there for those kinds of solutions. So my main question is for you, Michael, which is, I know you want to do a national survey and best practices and stuff, but we're not there yet. So can you share any kind of idea of what documentation of confirmed understanding would look like, such that could be one of the levers to achieve cultural change in an organization?
Yeah, so I think that it really depends on the context. So actually, I'm a fan of BICEP. You heard about BICEP this morning. Part of why I like BICEP, besides the particulars, but just in general, BICEP says, the fox guards the chickens, right? The person who's doing the consent process is actually going to be evaluating it. So BICEP says, let's not have the fox guard the chickens. You're going to have some third party remotely see if you've succeeded. And so that format is not going to work in all clinical settings. It's particularly good for the clinical trial networks. It's particularly like where it was tested. EQUIC didn't work, but BICEP worked. And at least in theory, the idea would be that you'd have a third party, so it's not just the fox guard. Now, most clinical settings, you're not going to do that. It's too much. It's too much. So are you asking, what's the format look for how you evaluate comprehension?
Well, what is that documentation? What is that supervision? What are we telling people that they need to change in their care settings?
So towards the end of your toolkit, there's a page.
Our toolkit.
Okay. Towards the end of our toolkit, there's a form for evaluating comprehension in the context of research. And, so that would provide a document that people could go and look at and then discuss with their staff. Right now, a lot of investigators do not talk with their recruiters or their enrollers about much of anything. If it's working, they don't. If it's not broke, they don't fix it. That's how that. I can't prove that to you, but by and large, when I've talked with research assistants, they say we didn't get any training and we don't get any supervision. So I have thoughts, but I don't want to.
Let's go to Lori.
Thanks to both of you. That was a great presentation to wrap up the day and gave me lots more thoughts. Thinking about cultural shift, I think we still have a ways to go even beyond that, and that is that patient priorities and preferences drive all conversations. And I think we still are jumping in the middle of that. So that idea of shared decision-making isn't about us taking time for the patient to get on board our decision, but in fact, that bi-directional thing. And so confirming understanding, I would love it to be us to confirm the understanding, us to use teach back and say, what I hear you saying is you prefer this. And to take the Hobson's analogy you brought up, I think for clinician teams, they have such finite amount of time and are taught in this method that suggests that we know better than the patient, that they are choosing between 2 negatives. How quickly can I get this? And so loved your comments on that.
So I actually just finished a month on the wards, which was a fabulous and intense experience because it's July, right? Don't get sick in July, right? So, you know, the clinicians complain about the time all the time, like the time all the time. They spend more time with the computer than they spend with the patients. Okay, so I don't have all that much compassion about this topic. Actually, I think that values clarification and agenda setting, bidirectional agenda setting, I think that's part of what you were starting with, is actually potentially time saving. And if you think that you know the agenda and actually, you know, you're leaving the room, either that you haven't fulfilled part of the goals or like it comes up at the end and now you're, so, you know, the issue of how much time it's taking, doctors whine a lot about this. Now, what I think should happen is that the insurers should get involved and say, actually, it matters to us that you meet their agendas. And maybe it has to happen in more complicated ways. Maybe before you meet with the doctor, someone can figure out their agenda with them, and you can walk in and we can empower patients, and people have done studies like that. So I think there are different ways to do it, but there's a cultural shift to happen. I completely agree. It's not simply, you know, it's much broader. You know, but when patients say to me, I don't know, you know, did you have the prostate, you know, screening test? I mean, like, you know, you sounded pretty confused about whether or not I should have that. You know, I'm trying to, you know, do a shared decision-making thing, and they say, oh, well, you know, you went to medical school. Do you think I should have that test or not? And so, you know, I try to talk about them, and I say, no, I want you to make this decision, not me, and it's fine. Well, did you have the test or not? Just tell me, should I have it? You know, it's back and forth, and that's all fine and good. But if the person says to my colleague, Jane, did you have that prostate test? So they didn't understand. Right? They just didn't understand. There's a huge misunderstanding. If they asked Jane if she had her prostate-specific antigen test, they didn't understand. Thank you.
I want to just circle back, Cindy, to your comment, and it ties in a little bit with what Lori brought up. So I think we have to be careful not to throw the baby out with the bathwater around technology, and I would argue that one size fits none, and that we really, things are very dynamic. Maybe tablets are not at all what we need to use, but then again, it may not be that you need Wi-Fi. It may be that a WAN signal is sufficient, and maybe people are going to be doing more of this at home, or maybe they're going to be using the kiosk in the waiting room. I mean, there's all sorts of things that are very rapidly changing, and I think we should think more about what the technology can bring and less about sort of what the hardware is that we deliver the technology. We had an experience recently. We got a grant funded with NIAMS where we were doing storytelling, and we said we're going to roll this out with doing it all on the web. And we realized there's some generalizability issues, but that's really the preferred platform, and we see, you know, the Pew numbers suggest that it's going up, and even among older people, more people are on the web at some point. Well, the review panel, of course, says, no, you can't do that. You need to also use DVDs. So we spent all this extra money developing the DVDs. Guess what? Nobody does the DVDs. Everybody goes to the web. So, you know, it's just things are moving, and when we try to dumb the technology down, we're always a step behind.
I completely agree, but it's also about we do need to plan for the future. Some things are moving so fast. I was on the wards just now. Everybody in the team had a device like this, and half the patients. And half my patients are homeless. So, like, you know, they all had a phone of one kind or another. And most states actually will give phones to homeless patients too. So, you know, maybe not a smartphone, but you could do IVR. There's all kinds of possibilities.
Andrew?
Just quickly, Michael, you just made my wrap up a lot easier. So I was getting worried that these issues were actually not going to emerge today. So just thanks for that talk. And I would suggest, because it is a different culture, a lot of what people are looking for is actually already happening in the social sciences, because they approach people from a very different perspective. So some of these missing best practices in the clinical context are already out there. They just haven't been discussed here today. That's it.
So thank you both, and thanks for your passion, Michael. It's just, it's great at the end of the day. So, you know, we love having friends like that, so thank you. That's great. We appreciate it. I wanted to go back to the same thing I said earlier.
I couldn't possibly have you fall asleep on me, Ruth.
Not you. No. We go way back. I know what you do on Friday mornings. Okay. He cooks and he drinks wine at home, just so you know what that is. So anytime you want to get Michael, you call him on a Friday morning at home cooking. So I wanted to go back and ask, I like that you put forth what you consider some recommendations, since the IOM Roundtable cannot offer recommendations, but we love to think about what they could be were we able to offer them. So thank you for putting that out there. And I wanted to push you both to think a little bit, because I think you two can represent this. Michael, you've just come off the wards, and we're talking on the other hand about a drug study in the field. And as I think about informed consent and the fact that we're trying to put shoes on all of them, I'm thinking about whether or not maybe they do need shoes, but the shoes are incredibly different. And as we look to the future, what the shoes for whatever this is really is, whatever the word is. And so I look at those and I think, I'm not sure from a health literacy perspective, if we take the public and the patients and the people, what does the public need to understand and know about that drug? What does the public need to know and understand about a procedure they're about to have in the hospital? And that, to me, is really the essence of it. So as I think of those recommendations, what I would like to also really push, it's not a recommendation, it's a strong thought that I would put on his list, is what is the need to know to do from the public perspective? And how do you push to make the right people make us confident that we know what the need to know to do is? Because we can't communicate it in English or get it to another language until we're clear on what the need to know is. So maybe in the world of the pharmaceutical manufacturers and the device makers and whatever it is, if we have more clarity on what it is, they are confident from safety and efficacy needs to be known and understood, we're more able to figure out what pair of shoes we're going to put on. So I throw that as a potential consideration, not just shortening and simplifying, but clarity on what it is the public needs to know and understand.
This is a big, big problem. This is actually, it was alluded to earlier, this is what is the content? And I can tell you a few things. One is, so in developing some of these systems, I wanted the user to be able to ask questions about side effects and this and that and the other thing, about a whole mess of medications. Went about a process to ask a bunch of clinicians, what are the key things that you communicate to a patient about this, about this, about this? The kappa was horrendous, right? The level of agreement that the clinicians had with each other about what you need to know to be able to take this medicine was horrendous, like really bad. And so we had to go through a whole process of discussing and managing and deciding, what are the critical things to communicate. But first of all, right now, what they get is from the direct-to-consumer advertising, right? So what they get about the medicines is all that they get in the advertisement, and then they come in to see me and they say, can I have that side effect? Please? Some of you knew what I was talking about. All right. Thank you. So, it's actually very hard to distill down the clear message about what the content is for all these many, many, many scenarios where the clinicians did not agree what the critical information was. And that was even before you brought in a reasonable person concept into the conversation, into like what a reasonable person would say would be needed to know. So we did this thing where we said, this is the information for each of these medications. Over 1,000 medications. This is the critical information we will deliver. And then everything else people would go and find out if they wanted to drill down. And people didn't drill down at all, right? They took what we demanded to give them, and then they never drilled down. We spent thousands of hours building additional questions that they could drill down in, and they never use it. Now, if you ask them, do you need this information in the system, they'll say, oh, yeah, we have to have it in the system. It was not used.
I think part of the issue is that we're losing the signal in the noise. And we're all driven by risk aversion. And because we're so busy consenting for things that aren't important, both in clinical care and in research studies, we're not doing a good job when it really matters. So this is a public relations campaign, trying to get out the word that getting medical care is dangerous, and there's benefit to being part of a learning healthcare system, and there's public good in that, and that there's an ethical framework for promoting that. So how do we educate the public better about this, and how do we somehow figure out a way to focus on what's really important and get rid of the rest of it? That would improve things dramatically.
Bernard.
Bernard Dreyer, New York, pediatrician. Michael, so you woke me up too. I was like half asleep, and you really woke me up. But I applaud your passion, and I feel your anger too. I'm as angry as you are, and so my problem with my anger is I don't know how to vent it effectively. So just two questions at the meta level, which you mentioned, which is that all the I don't know what the right word, all the powers that be are happy with the way the system works now. They actually don't want to change it. At least that's my experience. So therefore, how do we make them change it? And then the other aspect, you properly pointed out that confirming understanding is like the major lever of trying to communicate regarding the consent. But likewise, getting anybody to use those methods, teach back, ask, tell, ask, or whatever, to confirm understanding is a Sisyphean task in that, I always tell the story that we trained all of our pediatricians regarding an asthma research project to do this, and they did it well. They did it every time the research project stopped, and they stopped doing teach back immediately. So how do you maintain people doing confirmation of understanding that even when they know that it's good and they know how to do it, they choose not to do it?
So a couple things. One is, in fact, this is not like the cooking machine, this cooking thing. Like you can put a turkey in it and like you set it and forget it. Like you can't put it on the counter and then you come back like later and expect that everyone's still doing it, right? So I don't know. Everybody, you have one of those at home? You have one? Does it work? I always thought it'd be cool, right? What? Oh, you forgot it. You forgot it. Right. So this is definitely one of those kinds of things that requires supervision, requires feedback. So not in this context, but in a completely different context that I've actually had the opportunity to talk to this group about, which is the care transition context for Project Red. This is one of the things that we've been promoting in that context. And a lot of hospitals think, oh, we'll teach the teach back, and then everyone's doing it. So it doesn't work that way. You actually have to have opportunities to observe and then give people feedback, and then explain that actually this is the way you want them to do it, and build it in. Now, I could say that there are some health professionals that seem easier to train than others for this kind of thing. And at least in my experience so far, for example, I've been able to engage clinical pharmacists to do this, and they seem to actually do it. Just as an example. They're also much more likely to ask patients if they can actually afford the medicines. I want the doctors to do that too, but they seem to not want to do it. It seems so basic, but this is a broader cultural issue that for whatever reason, medical schools somehow communicate one way or the other that patient education and empowerment is somebody else's job, somehow. And so these kinds of interventions at the doctor level seem to be harder to do, even Sisyphean.
About the powers that be, how do we change the culture above the doctors?
Well, that's an awesome question. Look, so I think somehow it will require organizational change at different levels. So, could this happen at Health and Hospitals Corporation and come out from the organization? I mean, I trained at Bellevue too, and so, even if we tried to do something there, it won't actually stay there, and it'll have to spread through the whole organization. This actually takes a lot of leadership, and it takes a little bit of gumption. I think, finding lawyers that can be compatriots in this, they don't somehow feel like they have enough power to make changes. And inherently, risk-averse people become risk managers, right? So we're asking them to do something that may actually be risky for them, for their jobs or for their relationship to their insurers. Something's not, we don't have enough power. I meant their liability insurers, Steve, as opposed to like the insurers. This is another source of power, by the way. The insurers actually could put something, could actually set some of the agenda. There are some payers that actually, when they walk in the room, people were like, "Oh, they control 40% of our beds. Maybe we have to do what they say." You know, so the payers could have a role. You know, just to say, you know, we want you to evaluate their agenda and actually document that or comprehension. They could partly, you know, why do they control a lot of the disease management themselves? They actually have millions of phone calls with your patients right now every day, and that there's a lot of power in the room that hasn't been tapped for this agenda.
So you go ahead and make a comment.
Yeah, I think I'm on page with you, but I want to make sure because I think we have to think about how the system and how non-physician health professionals can help fix this problem. You know, I have a boutique practice. I'm not in clinic very much, so I can say this as a clinician, and my clinical responsibilities are limited. But my colleagues and friends who are primary care docs, they can't take one more thing on right now. And you can see, you just have to open the paper and read about the national shortage we have of primary care docs. We can't give them one more thing to do. We've got to figure out another way to take things away from them. And if it's the pharmacist or the nurse educator or you know, the 1-800 number or the person on the web, we've got to come up with a solution that doesn't involve adding more responsibilities to primary care providers.
So Rob,
question. Excuse me, Rob Logan, National Library of Medicine. Michael, I think this question is basically for you. Is the ultimate or foundational goal of the pedagogically oriented paradigm that you advocated, is it actually more shared decision making? Because that's what you concluded with. Or is it to empower those who have the least influence in the consent process, patients and caregivers? Is it both, or is it late in the day and I just missed your point?
Well, I'm not sure. I think it really depends on the context. I think that I'd like it to be about empowerment. I guess it depends. We can talk another time more later about what we mean by shared decision making. Sometimes shared decision making can be I want it to be empowering for people. One of the reasons why I'm worried about the subjective standard is that I think that a lot of times people look at folks whose teeth aren't straight, or look at folks who don't look like them, or look at folks who, you know, don't have the same vocabulary and say they don't need the information. So the shared decision making requires empowerment to even get to that point. So they said they get intermeshed, you know, so you can see that actually people who are more educated are given more information by their clinicians. And it's complicated. It happens bidirectionally. And so if you ask fewer questions, you get less information, and somehow the doctors look at you. You know, if appropriately empowered, are all the people not asking questions, are they just gut people? They're intuitive people. They don't need the information. They just want to know if they trust you. Or can they be empowered and actually get to a shared decision-making space? There's a whole kind of research agenda out there about gut versus brain. And I think a lot of people get pigeonholed into, oh, this is a gut person, I don't have to tell them everything, you know, because their teeth aren't straight or something like that. And so that's, you know, it's complicated.
last question, Kim.
Oh, well, Kim doesn't have a question so much as a comment, but thank you both very much. A great way to end our discussion today. And I want to say thank you, especially for the summary recommendations. As my colleague Ruth mentioned, that, you know, we're not of the practice of doing that. So we appreciate you putting that forward for good discussion. And I just want to reiterate the comments that I've been hearing about how one size does not fit all. How, you know, there have been multiple channels and avenues that have been explored to see if an iPad or if a paper form or if whatever, is the magic bullet. And there is no such thing, because each person, each individual has their own style of learning and has their own, is in their own space in terms of their health need and whatever at the moment that this is occurring. But I just want to take us back to our introduction to the commission paper that we had today to reinforce the importance of the discussion and of moving forward in this area. To quote, that studies have shown that most people, regardless of literacy level, are unable to recall or understand the information presented to them during an informed consent process. So that is our challenge. We're solving for nearly everyone.
So thank you. I'm going to make a comment too before I let you guys go. So really appreciate the back and forth about the technology and the utility to different segments in the population. I think there's a lot of utility in that back and forth in your comment, actually, Ken. So really appreciate that. And I too appreciate, Michael, your energy and passion, enthusiasm, but also the summary recommendations you put forward. My impression is, though, that a lot of us are too close to this issue and not seeing the forest for the trees. I have a sense that as important as these recommendations are, they only take a chunk of a much larger issue. And I think one of the things that I've gotten from today is the fact that informed consent is really part of a larger patient education, patient decision-making framework. And I don't have, at the end of this day, a sense that we've got a good logic model that encompasses all those things, or really our arms around that. So that's one thing that, and in a minute I want your comment on that. So that's one thing I walk away from. The second is the change model. From the current state to the future. Earlier on the earlier panel, I believe it was Alicia Fernandez who talked about the language issues, and I guess I'm no expert in any of these things, but I really have the impression that you and your staff are among the world's best people in understanding some of these issues. And then in your very same presentation, you made the comment that the implementation in your own institution was so slow, painfully slow, which is not uncommon. I'm not picking on you at all or your institution, but that's not at all uncommon, especially in academic institutions where you have some of the smartest people and yet some of the performance that is not necessarily benchmark. And so I really wonder if of our change models, being smart is just not good enough. Having passion is just not good enough. And I'm just wondering what a list of those recommendations might look like, Michael and Kenneth, if we were really backing off and taking a bigger view of this issue in terms of what kinds of things we might do. It's almost like we need the smart people that are in this room to come to a not a conference like this, but a working session where we would have whiteboards and stickies and get people working on processes and take advantage of their knowledge in a different kind of way to understand the issues and try to create solutions. The other thing that I wanted to say is that I don't think we should look up or down or sideways for the solution. I think the problem is us. And I think if the problem is us as clinicians, as leaders in our institutions. And if the culture stinks, it's because we've helped it to stink. So, those are a couple of comments I would make in addition. So any reaction to those kind of general comments?
Well, I'll just add one suggestion, and that is, this is a phenomenal group with a huge level of multidisciplinary expertise, but what I see missing from this room are patients. And we're all patients, but we're not some of the patients that we're concerned about. We don't have too many people in here, I doubt, with a high school education or less, maybe nobody. And we don't have, quite as much diversity as we're dealing with. There are people that don't maybe speak English as their native language. So that's the perspective that we need to bring in, and particularly in the era of patient-centeredness. We need that perspective, and that may embellish your list considerably.
Yeah, it's culture. The organizational change is tough, and I've seen a lot of projects fail because of poor management or poor commitment or not having the resources. There's a lot of ways to fail. It's amazing how many ways that this stuff can go wrong. I do think that there are some structural changes that could help, that could actually change things. And I do think that an organization can get around a campaign for these topics and then build from that campaign. It would have to be a whole campaign. It would have to include marketing. It would have to include infrastructure. It would have to do a whole campaign. The whole organizational change thing is unfortunately, people just somehow don't get these topics into that headspace. You know, but that's the kind of thing it would take. And still, it would take a generation of trainees, multiple generations of the trainees to get through that. And, you know, it happens at so many levels. You know, on the wards just now, I heard the patients, one of the residents say to the medical student, that guy needs blood, go consent him. And so I said, hey, everybody, let's sit down together. You know, and then we talked about the scene that was about to unfold. But that's hard to actually, you know, get that to happen. You know, I happen to hear that, like the resident says to the third-year medical student, get the consent form for that blood, you know. But it just happens that I got that moment. And, you know, but if you can change, it takes all those things to change, you know. So we sat down, talked about the whole thing, and then we, you know, I explained why I care about that form, why I care about blood, why, you know, all that kind of stuff. How many errors that can be made out of this. What does it mean to send a third-year medical student? It's probably not legal anyway, blah, 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 blah. But it takes a lot of work, and it takes a lot of doing. Thank you.
So thank you, and let's thank this panel. Terrific.